Hello, I'm Todd Featherling with Perception Health. Perception Health's mission is to inform and inspire the healthcare industry to deliver better care for the people they serve. We use innovative technologies to drive optimal health for people and improve the delivery of care. We help hospitals and employers optimize their care teams. It's my great pleasure today to introduce a friend and a healthcare luminary, Dr. Don Rucker. He's the National Coordinator for Health Information Technology, and he comes to the office of the ONC from the Ohio State University, where he was clinical professor of emergency medicine and biomedical informatics, and earlier at Premise Health, a worksite clinic provider based here in Nashville, where he served as chief medical officer. Dr. Rucker started his informatics career at DataMedic Corporation, where he co-developed the world's first Microsoft Windows-based electronic medical record. He then served as chief medical officer at Siemens Healthcare USA. Dr. Rucker is a graduate of Harvard College, the University of Pennsylvania School of Medicine, with board certifications in emergency medicine, internal medicine, and clinical informatics. He holds an MS in medical computer science and an MBA, both from Stanford University. Dr. Rucker, it's great to have you back in Nashville.
Okay. Well, thank you very much to the Tennessee Hymns for inviting ONC to speak. We obviously wish that we could have done this in person, but not the case. I think nonetheless, COVID has actually highlighted for us, I think, the importance of some of the things that we're working on jointly together. And before we get into that, I would just like to give a shout out to Tennessee Hymns. I've spent some time in Tennessee, worked with a number of folks at Premise Health, and have lots of colleagues at Vanderbilt. You've heard from Mark Frissy and just a lot of great folks. Will Rice and I have worked together, Mark Franklin, so many, many people in our sort of mutual circles. And I think what we're talking about, this feature here, I think a lot of it is actually going to happen because the entrepreneurial community in Tennessee is really, gangbusters for putting new products and services into healthcare. So I think it's a pleasure to be sort of at ground zero on this. And what are we really talking about here? What is that opportunity? Well, I think the real opportunity is the consumerization of healthcare. We've obviously had, actually goes back to World War II and the 1942 Stabilization Act during World War II, that to get around price controls made healthcare a pre-tax expenditure. Since then, we've had a whole set of policies that have made healthcare very much between payers and providers, but the consumers really haven't been in the game, as we all know, especially since Medicare started setting prices administratively back in 1965. So I think we're at a inflection point. I hate using that word, it's a little bit of calculus, but maybe this is the time for calculus. An inflection point where consumer sovereignty will come back in. And it's not necessarily because everybody wants it, the consumers want it, others may not, but because the technology is going to be so powerful for consumers to get back in the game that they will, just as they have transformed so many other industries, whether it's publishing, printing, travel, entertainment, finance, all of those things have been transformed by smartphones and global presence of information shared by consumers in ways that they've never had the opportunity before. That world is, I think, coming to healthcare pretty quickly. Probably the big event, I think we'll look back and see as the big transition event, if it wasn't just the invention of iPhone, probably more accurately, the big transition event is going to be the 2016 21st Century Cures Act. And the Cures Act passed almost unanimously by Congress, signed in at the very last month of President Obama's term, made it the law that patients have a right to their information digitally, and that there should be a requirement for standardized application programming interfaces to make that operationally practical. So those are very, very powerful provisions. We have been, as folks know, very active in making that, operationalizing that through the ONC Cures Act interoperability rule, which was released this spring, and a companion rule from CMS on interoperability. As folks are probably aware, consumer empowerment has been a huge priority for President Trump and the administration, Secretary Azar, Administrator Verma. So you've seen a big effort throughout our administration to really get the public back in with this modern technology. And obviously, it's, it is a major change, but I think certainly in Tennessee, where there's so much entrepreneurial activity, so many folks, I know Todd Featherling's been involved in some of these things, Powered Health, so many folks there. I could be here for an hour naming the great teams working and being smart on data in Tennessee. It will be a great opportunity to bring all of this to patients and really immerse patients and rethink the bricks and mortar versus the virtual, and come up with new services, new ways of providing healthcare. So let me go a little bit through some of the specifics of the rule for this audience, just so you're up to speed on that, and then talk a little bit about some of the surround policies that might be out there and how this might play out over time. So the three provisions that the Cures Act has on interoperability: one is prohibitions against information blocking. The second is application programming interfaces without special effort. And then the third, in a great federal acronym generating activity, is the Trusted Exchange Framework Common Agreement, to have the various health informations talk to each other. So those are the three provisions. I should point out, as we are here, that we anticipate any day now having a rule affecting the timelines on information blocking and some of these APIs adjusting for COVID in federal regulatory speak, through the Administrative Procedure Act that is sitting at OMB and on their ledger, so you can sort of see that in progress. But I think I can safely say that this will be out very soon. We obviously understand that all of the provider IT folks have been very busy with COVID, and we want to be maximally respectful there. It's interesting, of course, that had these rules and these APIs been out 3 years earlier, our ability to work around a pandemic would have been so much more powerful. I mean, we'd have telehealth much more richly and deeply informed by the patient's medical record, more ease in getting care, arranging consults, knowing what lab follow-up is, a lot of the things that, and just virtualizing, just keeping distance. I mean, to be absolutely spot on in terms of prevention. So this is coming, I guess in the better late than never category, but we, will put us in good stead because there will be other viral pandemics as the biology plays out, especially in the areas, in particular the Chinese wet markets, that appear to be extraordinary sources for generating multi-species selected viruses. So what are the three provisions? Information blocking really says the patient has a right to their information and a right operationally. It's not just, dragging your butt to medical records and giving them some paperwork. It is really in making fully aware. There were some prior ways of doing it, certainly, but the modern smartphone economy and smartphone apps be the tool to get patients their data. And we have a number of allowable exceptions to protect privacy, security, uptime, because these things are very economically charged in terms of providers, competition. We've also put in some rules on allowable fees. We've spent literally 2 years working to have the appropriate balance between the rights of EHR vendors to, finance and build and reap the rewards of great products, the exigencies of providers who have an EMR and will, likely have to use their EMR to provide the API, so they're not, they're not trapped by these things with no place to go. And then finally, allowing patients to get their data for, quote, free. And of course, nothing is free. These are costs borne. But as with many, many federal rules, the costs really should be part of the process of care. We think just as discharge instructions on paper are the process of care, letting patients have access to their medical care that they, and often in many cases, the American taxpayers have paid for richly is an absolute must. So that's what you're going to see out there. If you go to healthit.gov, you can see the details about the exceptions. I think if you look at the exceptions, you will see that if you were in our mandated shoes of implementing what Congress passed and the president signed, I think you would come up, I believe, with something remarkably similar. But that's for you. That's for you, obviously, to sort of think about. The second concept here is really Congress realized, and it's very interesting when you meet with members of Congress, as a O&C person, it's not about the API or the technology or the data standards. It's not about any of that. It's a story of they went to medical records and they try to get, their MRI or their mother's MRI, and they couldn't get it. I mean, Secretary Azar recently tells a story of trying to get his medical records in Indiana, and he was not able to get his medical records out. Pretty stunning when you're the sitting Secretary of HHS that you can't get your medical records out. And I think many of us have had very, very similar stories with, re-imaging, further expenses, retesting, not as great care just because we haven't been able to move these records around. So the big thing about application programming interfaces without special effort is we are in this transition from the classic HL7 version 2 type of data streams to the modern FHIR, Fast Healthcare Interoperability Resource data streams using RESTful APIs. Obviously, FHIR is a JSON data standard. This is the way the modern world and app economy is going. There's extraordinary interest throughout healthcare in these APIs. Earlier in the summer, there was a FHIR Dev Days conference. There were 700 developers FHIR developers participating in this FHIR conference. We working with HL7, who now manages the entire FHIR process. So very exciting times. Couple things to sort of note there. How does this actually work? Like what is this? The way it works is and this we anticipate will be typically the EHR vendors will provide a FHIR endpoint, so a server endpoint to their medical record product. And then patients will, using the developer directories of providers, access the, you pick smartphone apps of their choosing and using OAuth 2, authenticate and authorize whatever information they want the smartphone app to download. OAuth 2, as folks know, is very secure. It's what is used in banking and other, important financial transactions that are, equally important to, healthcare privacy. Certainly, getting your bank account and your retirement accounts wiped out is, protecting that is absolutely critical, protecting national security. So those are the types of OAuth 2 things. We're using the modern industry standards as part of the rulemaking there. This has brought up a number of discussions, as folks may know, that are really globally part of the discussion about privacy and security. So I think on security, right, so that sort of wire security, that encryption, I think the OAuth 2 and that's a pretty well known, at least to current known security risks, a pretty well-known and secure pathway. Obviously, there's all the usual issues with passwords, server protection, operating system updates. I think the broader question is how do you protect privacy? Now, we let and encourage the EHR, users, right? So the doctors and hospitals and the EHR vendors to put stark warnings that the patient is removing their data to an app, and they need to decide whether this app is secure and will respect their privacy. This is just like giving patient, someone the password to your checking account, right? You want to be, or you're giving them your ATM card. You want to be very clear here. The access here, by the way, is under the individual HIPAA right of access. So this is something that has not, that part of HIPAA has never really been robustly used in a technical way. Provider portals, which are used by some of the population, use that, but this is really the first full way where patients are empowered to take their data and use it for purposes of the patient's choice, fully for the patient's choice. We have put in a number of provisions on disclosure of privacy policies. These things are enforceable under the law. As folks know, the Federal Trade Commission enforces both deceptive business practices and unfair business practices, both of which would be implicated if an app does things that they have not informed the consumers of. There are also, in many states, private causes of action. So we have used all of the legal protections we can to ensure that patient data is protected. So again, the goal here is to have a modern app ecosystem to give patients new services of all different kinds. I personally think these things will start with, consumer-friendly versions of the medical record. I can easily imagine all kinds of apps using all the data that they have, that the patient has allowed them access to think of, different ways of explaining care, of presenting options. We think these things will, over time, go hand in glove with CMS price transparency rules, especially over time. I would anticipate those would be built out with standards. And, you have folks like the Blue Book down in Nashville and Brentwood who are already doing work on price transparency. So I think you're going to have, I think, a richly informed consumer experience the same way with every other consumer product that we buy. I think this will be part of it. And then over time, who knows where this will go. I think there will be different mixes of bricks and mortars and virtual. Historically, we've had a very office visit based, a very episodic care thing. But as these smartphones, the Internet of Things, these become medical devices or medical sensors. I won't say medical device, that's a very specific construct. But as they allow, let's say, a richer interaction with our biology and physiology, I think all of these things will come together in totally different ways of thinking how we provide care for patients, and the ability to make that a much more rich, a much more successful, and a much more preventative process. There's one other part of APIs I would like to just alert the Tennessee HIMSS audience to. which is in the HL7 version 4 fire standard, there's also something called a bulk fire API. So as we were working with various developers and vendors and academics and interested groups on the individual APIs that would go into smartphone, we realized there were no standards on fire to get out a population of patients, for population health, for example. And so the HL7 group, working with Ken Mandel and Boston Children's, a whole number of folks, a number of the big EHR vendors, Microsoft, Josh Mandel, some of the folks at Apple have put together a standard that allows all of the medical data on a population of patients to be accessed. Now, that is not an on-demand access whatsoever. That is not like what I just described with individual patients. This is a standard HIPAA transaction under, it's not a standard HIPAA transaction. It is a transaction, a data transfer that would happen under the HIPAA treatment, payment, and operations protections. That is a signed contract where both the providers and the payers or whomever as a covered entity or business associate would be doing this would have a standard covered entity business associate contract. That is not on demand. That doesn't just happen, but it is an opportunity afforded to providers to use modern technology in a way that you don't have to spend your dollars on custom APIs for every business counterparty, because that is just a waste of time and energy. So it is a modern thing. It's going to, I believe, be transformative because it's going to change things like whom we decide to buy care from. If you're a payer, it's going to change the dynamics of what providers can do, the interactions they can have, the risk contracts they can sign. And I think ultimately, frankly, it will get rid of two of the biggest failure modes we have in American healthcare in the search for value. And those are the failure modes around prior auth and quality measures, right? If you think about quality measures and prior auth, they're basically circa 2000, year 2000, attempts to figure out value, to not buy things that have value perceptions that are poor. But they've both been built out in very manual, highly curated, highly one-off, and highly narrow ways that generate all kinds of burdens throughout the system. They're absolutely painful for patients. I mean, I'm currently involved trying to work through some prior auth stuff for my own care. I've already spent hours on the phone for something that should be an absolute no-brainer. This is just true throughout the entire system. When we have bulk data where we can do the search for value using modern machine learning techniques and big data, I think some of those burdens that add no value will go away. So that's transformative. I wanted you to be aware of that. The third part of the Cures Act was, again, the Trust Exchange Framework Common Agreement. I think part of the activities there that are very important are the role of health information exchanges. We've seen with COVID that a number of the HIEs are just extraordinary at providing the absolute richest COVID data sets. And the reason why is because the HIEs have patient-level identifiable information. So unlike mandated reporting, which would be, let's say, how many positive tests or how many ventilators or how many beds patients have a COVID diagnosis, with HIEs, you can track, what's the time from a positive test to a negative test to evidence of serologic immunity. What are the complications? What are the risk factors? How often are people going from one setting of care to another, or coming from a nursing home to a hospital? All of these rich COVID data activities, you need longitudinal care. We're working with a number of the folks. It's a complicated process to start shifting, getting data from, move more of the data to flowing through the health information exchanges that are already catching the data and having richer data, and try to shift away from all of this out of process mandated one-way reporting where there's no data reuse, additional costs, and frankly, because the data doesn't really have a lot of eyeballs on it, isn't really as good as the operational data that most of our HIEs have worked years to build out with robust enterprise patient matching, robust data deduplication, and robust normalization policies. And again, a lot of the states that the data feeds almost to the instant identification of outbreaks, precise to multiple decimal point identification of risk factors, all kinds of stuff. And the beauty of modern APIs are, we see some very good ways that the state and local health agencies can access this data. So the HIE serves last mile. And then frankly, with machine learning and split level learning, there are privacy protecting ways that folks like the CDC can actually start getting data without having, where the patient identifiable information sits at the HIE and doesn't move, but the layers of abstraction move for further analysis nationwide. Extraordinary technologies there, and that's all work in progress with health information exchanges. So, wrapping up here, I think couple points to make. Obviously, computerization and information and health IT are going to be the center point of healthcare if they're not already. That is inevitable. We have some big to-dos here. There's, still work on standards, building out standards, making them more sophisticated. ONC, Office of the National Coordinator, we're doing a lot of work. We're using your tax dollars to fund some of these activities for the public good. We're working with a lot of folks to start thinking about merging some of the clinical and financial data. So think something, for example, like X12 transactions where you might have a FHIR data packet of the US core data for interoperability. That key data that's in the first tranche of required reporting, which again, pay attention to rule updates that you may be seeing soon here on the due dates there. And so we're going to see that. I think we're going to see over time that those are richer data streams, a lot of opportunities there for businesses. I can think of a number of businesses in Nashville that'll probably jump at doing things there as we sort of refine the search for value. We're doing a lot of work with the global community, the Global Digital Health Partnership, so that these data standards are as international as low cost, opening up export markets for goods and services for the US. I was literally on the webinar this morning with the German Ministry of Health on some of the things they're doing. But all of this is going to come together the way it has in the rest of our consumer lives, as on the consumer side, a smartphone world where we have constant access to our data, patient-generated data, rich tools to use all this computer power to transform the way we can take care of our bodies. There was the book, I believe Our Bodies Ourselves, back in the late 60s or 70s, which was in the political narrative there on women's health, as memory serves me. But with smartphones, that enablement is really going to be global. That's on the provider side. On the patient side. On the provider side, the opportunities are just as rich. I went into this field to prevent myself and my colleagues from doing what back in the day was called SCUT, which is just no value add and essentially clerical work that was just stultifying, had all kinds of safety risks, delayed care, made care worse, was expensive. our EMRs have largely, as we know, been tools for billing and more billing with just little layers of automation on things like lab retrieval and now physician order entry. I believe in the next 10 years, as APIs enrich with the Internet of Things, we're going to see core EHR functionality, whether it's from current vendors, new vendors, and likely a combination of both, really automating the delivery of healthcare in many spots. Our inpatient units are rich targets for automation of every shape and manner. And that is, I think, the world that is out there. Tennessee, the healthcare IT community in Tennessee has been an absolute leader. Tennessee has the most robust entrepreneurial community for healthcare IT and the delivery of healthcare. Thank you very much, and we'll turn it back to the organizers. Thank you.